That's a great picture. Good evening, everybody. Thanks for coming, and I gather, are we also streaming this? Okay, and thanks to those of you who are joining us online. We good? Okay, thanks. It's good to see you all and to think about Pat and remember her and honor her today on her birthday. I'm not going to say out loud which one it is, but I know because it's the same year as mine. And as many of you know, Pat was a dear friend for a long time, and I'm so happy we're doing this. And thanks to Robin and Beth really for organizing this and making it happen. As many of you know, medical education was an important part of who Pat was and her approach to her career. I mean, she was great at a lot of things, and I miss her very much, but really medical education was deeply special to her. I think she felt that in addition to elevating the status of an organization, it also improved quality. And I think she also felt that it was part of what we were supposed to do as docs. I mean, this was really terribly meaningful to her, and it was an obligation she took seriously. But I also think the more I got to know her, the more she cared about teaching, not just creating an atmosphere that celebrated education and creating learners, but it was also elevating the art of teaching. And during the last year or so of her life, Pat and I talked on a number of occasions about, what more could we do as a growing organization that was rapidly expanding the number of residents and even medical students that we had. And we came upon the notion of a teaching academy, and it really captured her fancy as a way to create a forum that would celebrate educators, that would create a place where they could get together, get better at their craft, but also to create a forum that would promote the production of scholarly work and ultimately help advocate for teachers and education across the organization. And I remember, Joe, perhaps you'll remember this. I remember the last time I spoke to Pat, we were in the room upstairs, and I said, hey, Pat, we'd like to name it after you. And you know better than I, she was a tough broad at times, one that I loved dearly, but tough Irish broad. And, I saw tears in her eyes that day. This was very special to her. And I remember saying, Pat, would you want it to be the Patricia Tietjen or the Patricia A Tietjen? And she said, you put the A in there. So we have, and I make a point every time I see this thing, the A goes in the name. And I do want you to know a couple of things, not only you, Joe, but William and Billy and Jimmy and Sam, that she's very much with us. This program has done beautifully in many respects. I mean, Robin has done a spectacular job and aided by Beth, and Pat would be very proud. I mean, it's a success. There are any number of scholars who are here with us tonight who were part of that program. And an important part of education, as you all know, for Pat particularly, was the interdisciplinary nature of it. She was a huge fan of nurses as well as doctors and everybody else who was part of the team. And this program, this academy, celebrates that and underscores the interdisciplinary nature of that. So I think she would be proud that we had a program where the scholars presented their papers just a month or so ago, and they were remarkable, and the momentum continues to grow. So I do think she'd be happy. She is happy, and she is proud. But beyond the teaching academy, I would also tell you that Pat and her legacy are alive and well. I would say not a day, certainly not 2 days don't go by where somebody brings Pat into a conversation. And those of you who are here know that either somebody makes reference to a passion of hers, a program of hers, a priority of hers, and or will, even today, and this was in New York State, I was talking to a physician leader who knew Pat, and he made it clear that he had been mentored by Pat, but made it clear that this is how Pat would have approached things. Now, I will say that from time to time, as we're, occasionally I have disagreements with people in my role as the chief executive, and there are programs that people are battling for or budgets that they're insisting upon. And, when you're getting down to the last hand and somebody's looking for the ace up the sleeve, they'll say, and by the way, I know that Pat would be opposed to your idea on this. So they don't hesitate to play that card because they know it kills me to hear that because then I have to stop and think. But honestly, she is adored, she's admired, she's remembered. And I think that she set a standard that we all try to match and live up to. I think Dr. Rivera may speak to this. I know it's a passion of yours about the role of women in medicine. And Pat, in 2008, I think, Broderick went down to St. Vincent's and helped recruit her. But part of the deal was, she was one of the first chairs of medicine in the US. And then years later, she became the first chief medical officer. And as you know, only 3% of the CMOs at the time were women in the United States. So she was incredibly successful and admired. And the only thing that I would say that has declined, and it's declined precipitously, is the quality of footwear in this hospital. I just don't see the gorgeous shoes. And there's a pair of Pat's to remember her today. But I do want you to be proud and know that we honor her every day. And this academy will live on for many, many years, and it will inspire a generation of educators in her sweet memory. So thanks for being here tonight. And with that, I'm going to turn it over to Robin, who's done a beautiful job with the program.
Hello. Thank you very much. I now have the honor to introduce Dr. Rivera. I could not be more pleased to present Dr. Rivera to you. Dr. Rivera was Pat's co-fellow at Memorial Sloan Kettering. Since then, she spent a long while as faculty at the University of North Carolina. She founded the first multidisciplinary thoracic oncology program in the United States. And demonstrated the vital role of pulmonologists in the care of patients with thoracic oncologic disease. She also founded the first multidisciplinary lung cancer screening program at the University of North Carolina. And she's going to speak to us today about lung cancer screening with special attention to underserved populations. She's one of the most wildly successful physicians you'll ever meet. She's published over 100 manuscripts in high impact journals. She's written over 20 book chapters on lung cancer. She's participating in high quality research, examining the role of navigation programs to promote lung cancer screening in Black individuals in underserved communities in the United States. She is to serve as the ATS president in 2023. She serves on the Pulmonary Exam Committee. And in 2019, she was awarded the Assembly on Thoracic Oncology Lifetime Achievement Award. However, out of all of these achievements and accomplishments, in my phone call with Dr. Rivera to prep for this conference, she said that her single greatest honor was receiving the first annual Pulmonary Critical Care Division Faculty Teacher of the Year Award. Teaching and mentoring is near and dear to Dr. Rivera's heart, as it was to Dr. Tietjen's. And as I found in one of the many articles written about her, her passion is teaching future leaders of the pulmonary medical profession. We could not be more honored to have her with us tonight. Thank you.
Thank you very much. Hey, that was very lovely. I met Pat Tietjen 4 years ago tomorrow, our first day of fellowship. She wasn't supposed to be at Sloan Kettering. I was asked to be a chief resident, and at Sloan Kettering, you became a chief when you were a PY5. So you had to do a year of fellowship and then come back and do chief resident. And Diane Stover panicked because she was going to be without a second-year fellow. It was only one fellow a year. And she recruited Pat at the 9th hour from St. Vincent's. She wasn't thinking about a fellowship, but was recruited by Diane. The first time I met her, she was wearing 3-inch heel leopard shoes, and we had a code. And I thought, oh my gosh, this woman's gonna kill herself. She was running so fast. And she turned to me and she said, keep up. I was like, we were very different, but we shared similar passions, and she was one of my dearest friends. Every time I needed advice, she was one of the first people I would call. This photo was taken of her. This photo of her was taken at my wedding. We had so much fun, and I think she is truly one of the most amazing people I've ever met in my career, because she mastered the art of and the science of medicine. Her professional quality and integrity were impeccable. But I think I remember her best because of her humility. Pat was great, but she was just Pat. In addition to her passion for education, she had an unwavering commitment to equity in healthcare. Every patient needed access to healthcare for respiratory diseases, at least when we were fellows, and then for her it became a mission across all medicine. And that has been very inspiring for me as well. I think we struggle with this in our healthcare system. So the topic for today is, disparities in lung cancer screening and some of the challenges, but importantly, opportunities that we face in order to improve access to this very important intervention for all patients at risk for lung cancer. These are my disclosures. I have no financial relationships that at all that would conflict with this lecture. As many of you know, lung cancer is the second leading cause of cancer in the United States among men and women, estimated in 2022, approximately 236,000 new cases. The majority of patients who are diagnosed with lung cancer in the United States are diagnosed with advanced stage disease. Thus, the chance of curing patients is much, much lower. Lung cancer is the leading cause of cancer death in the United States in both men and women, with the exception of Latina women who are more likely to die from breast cancer than from lung cancer. As you know, many of the first trials were started in the 1970s. In fact, at Sloan Kettering was one of the first clinical trials to evaluate the role of chest X-ray in lung cancer screening. There was no benefit demonstrated to lung cancer screening for over 40 years. When we think about lung cancer, it's important to remember that there are racial and ethnic as well as sex-based differences in terms of smoking prevalence, as well as in terms of the incidence of lung cancer, and importantly, the mortality from lung cancer. Blacks, particularly Black men in the United States and Native Hawaiians, as well as women, have a higher risk for lung cancer, but also a higher risk of dying from lung cancer. Particularly when we look at the amount of smoking, smoking is the most important risk factor for lung cancer. And we think about heavy smoking as the risk factor, but in fact, there are certain groups in the population who have a high risk of lung cancer, in particular Black men and Native Hawaiians, even having smoked what we call low intensity smoking, less than 10 cigarettes a day for a prolonged period of time. And this is also potentially may also be true for women. This was a very important study that was published just only a few years ago in the New England Journal of Medicine. And it was a study that looked at the incidence of lung cancer across different birth cohorts in the United States, compared women and men, and compared racial and ethnic groups. And notably, you will see that for the women are in red, females, I'm not sure if this is, can you see the pointer? Because I can see it here, but I don't think you see it there. But anyway, the females, okay, there you go. The females are in red and the men are in blue. And when you look at women who were born since 1965, so younger women, the amount of smoking in this group of women has approached the smoking rate in men, but it has not surpassed the smoking rate in men. And despite that, women born since 1965, particularly white women, Latino women, and Asian women are more likely to be diagnosed with lung cancer than men in the same age group who smoke more than women. And this is a very important aspect in lung cancer in women, that cigarette is only one aspect of the story, that there may be other risks contributing to the biology of the disease in women. But again, in the United States, it's important to remember that certain groups, and in particular Blacks, have a much higher incidence of lung cancer and a much higher risk of dying from lung cancer than whites. And why is that important? It's important because of disparities in healthcare. And when we look at disparities in cancer care, lung cancer is the one cancer that has been plagued with the most disparities, not only because of racial and ethnic differences in the biology of the disease and the incidence and mortality, but really likely more because of socioeconomic status. And socioeconomic disparities have a greater impact on lung cancer disparities than racial and ethnic factors. This was a study from 2011 that looked at differences in the prevalence of smoking, access to high quality screening, timely diagnosis, and treatment for Blacks and whites for all cancers. Social economic disparities were most pronounced in lung cancer. In fact, 5 times greater death rate in the least educated men. And if we eliminated socioeconomic disparities, we potentially could reduce 37% of premature cancer deaths. In African Americans, this averted twice as many premature cancer deaths as eliminating racial disparities. So it underscores the importance of this factor in terms of disparities in healthcare. As I said, for 40 years, the leading cause of cancer death in the United States had no approved screening test. We had screening that was approved for breast, for prostate, for colorectal, for cervical cancer. Lung cancer is the leading cause of cancer death, and there was nothing that had been shown to be efficacious, because in order to have a screening test that works, you must have a screening test that proves it can decrease mortality from that cancer. And in 2011, the results of the National Lung Screening Trial, the largest ever randomized trial in the United States, over 55,000 individuals between the ages of 55 and 74 who had a history of smoking or had smoked at least 30 pack years, were enrolled to a low dose CT versus what was considered at the time likely the standard, which was a chest X-ray. And they were followed for 3 years with an annual low dose CT or chest X-ray, and then followed over a period of 7 years. Again, I always tell my fellows, remember that we have had colorectal cancer screening for decades. There has never been a randomized trial comparing colonoscopy versus something else in colorectal screening. This lung cancer, the first randomized trial, 55,000 individuals. And what was so very impactful about this is that indeed it demonstrated a relative reduction in mortality of 20%. The first time ever a trial demonstrated that as an intervention to detect the cancer at an early stage worked. It worked because it reduced the number of people dying from the disease. 2 years after the NLST was published, the USPSTF, or the United States Preventive Services Task Force, which had always given a letter D to lung cancer screening, meaning don't do it because it can actually be harmful, assigned a letter B to low dose CT. And the recommendation was in patients, in individuals asymptomatic, 50 to 80, I'll explain that in a minute, they increased the upper age limit with at least a 30-pack year smoking history. And if they had formerly smoked, they had been quit within 15 years. So this was not for people who were quit for long, more than 15 years. The recommendation was to screen annually with a low dose CT, to discontinue screening once they reached the 15-year quit. Or the upper age limit, or if they developed an illness that was going to compete for death. So severe cardiopulmonary disease, stroke, etc. Again, a letter B, this was monumental. And in 2015, CMS approved lung cancer screening for individuals covered by Medicare, which was also pretty remarkable. Why the age of 80? This was based on cisnet microsimulation by the USPSTF, which identified individuals as high as 80 years of age as being more beneficial than if you cut it off at 74. An important observation about cisnet microsimulation, and that doesn't take into account racial, ethnic, socioeconomic, and sex-based differences in terms of the prevalence of smoking, in terms of the incidence and the mortality from lung cancer. So we're only taking age and smoking, but as many of you know, there are many other risk factors that play into lung cancer. So for quite some time, although we were very excited, as you can imagine, that we finally had an approved intervention to detect lung cancer at an early stage, there was a great deal of angst that the 2013 USPSTF criteria were not aligning well with certain groups of individuals at risk for cancer, particularly vulnerable individuals, Blacks and women. Why? Because again, Blacks tend to get lung cancer having smoked less, and in fact, at a younger age, I'll show you in a minute. And what about the 15-year quit? There's still a great concern about that. From the Framingham study, we know that about 48% of lung cancers diagnosed in that study were in individuals who had quit smoking more than 15 years. And there were under or unrepresented groups in the NLST. Only 4% of the individuals in the NLST were Black. I think 1% Latino, no patients living healthy with HIV, a high-risk group for lung cancer, and only 4% of the individuals were individuals who had survived a prior cancer, also a high-risk group for second primaries, particularly lung. This was a pivotal study conducted by a good friend of mine, Dr. Melinda Aldrich at Nashville University, and her colleagues. It's data from the Southern Community Cohort study. This is a large cohort study. It includes 12 states. Over 48,000 individuals have been followed, and these are individuals who smoked, and they wanted to compare the characteristics of individuals who developed lung cancer, sociodemographic, how much did they smoke, how old were they, white or Black. And you will note that among African-American individuals, more likely to have less than a 30-pack year smoking history than whites. And in patients who developed lung cancer, when they looked at why were these patients not eligible to undergo screening, a significant percentage of Blacks compared to whites were younger than 55, so they would not have been eligible. And importantly, had smoked less than 30-pack years, would not have been eligible. So the criteria were excluding high-risk, vulnerable individuals in the population. This group proposed a model of decreasing the age and decreasing the smoking history in order to improve eligibility criteria in Black individuals. Following the NLST about 2 years ago, we had the results of the second largest randomized screening trial comparing low-dose CT to standard of care conducted in Europe. So not only one, but now we have two, and there are more. Second largest, this was about 15,000 individuals, asymptomatic, mostly men, Because at the time that the Nelson trial was started, women in Europe were not smoking that much. So only 16% of the individuals were women. These were individuals who were younger and actually had less smoking history than in the NLST. And they were followed with different intervals, 1 year, 2 years, 2.5 years, over 10 years with low dose CT. And again, another remarkable finding in that lung cancer mortality was significantly statistically reduced in patients who were randomized to low dose CT. And what's important is that if you note the mortality reduction in women, significant. The NLST tends toward better mortality in women than in men, but not like the Nelson trial. And since the Nelson, multiple other trials, a lot smaller, throughout the world, in Germany and Italy, that have demonstrated the benefit of low-dose CT for lung cancer screening in terms of lung cancer mortality reduction. Low-dose CT lung cancer screening works. Why does it work? Because we are detecting lung cancer at an early stage, and it does result in a stage shift. There's a great deal of argument that we were just overdiagnosing cancers that would not have been impactful. That is not the case. When you look at the trials that analyzed the stages of disease and you compare it to the general population, again, in the general population, the majority of individuals will be diagnosed with stage 3 or 4 disease. That is disease that is treatable but not curable. But the stage shift occurred in all of the trials, more stage 1 and stage 2, particularly stage 1 cancers detected, less stage 3 and stage 4. And lastly, there's been a great deal of criticism about lung cancer screening with low-dose CT in terms of the efficiency that you have to do hundreds and hundreds and hundreds of low-dose CTs to detect one lung cancer. Well, in fact, you have to do about 320 low-dose CTs to detect and prevent one lung cancer death. You've got to do about 1,900 mammograms to prevent one breast cancer death and 1,200 colonoscopies to prevent one death from colon cancer. So it is a very important intervention. And second to tobacco treatment and tobacco cessation, if implemented correctly, lung cancer screening has, second to tobacco interventions and cessation, the most important impact in terms of reduction in lung cancer mortality, at least in my lifetime. In 2021, given the volume of data that had been published since the NLST, particularly several more randomized trials, including the Nelson trial, and particularly the important findings from the Southern Cohort community study, the USPSTF revised their lung cancer screening recommendations. They lowered the age to 50, and they lowered the PAC years to 20. They left the quit year the same, and they did not endorse using risk modeling in order to better understand who was high risk and who might be eligible. All other criteria remain the same, but this is an important step. This is an important step in terms of capturing more high-risk individuals and perhaps more high-risk and more vulnerable high-risk individuals. What does it mean? What do the new criteria mean? It means that now 14.5 million adults in this country are eligible for lung cancer screening. It's an 81% increase over the 2013 recommendations. These criteria increase eligibility for women, for non-Hispanic Blacks, Hispanics, and Asians. It is estimated that there will be an increase of screen-detected cancers by about 21%. And importantly, that greater gains in lung cancer death averted in women compared to men. And despite these important improvements, there are challenges that we face. Have we really eliminated disparities in eligibility? It was highly publicized in 2021, as you may recall, that these new criteria were going to eliminate disparities in terms of eligibility. Is that really true? How should we optimize risk-based assessment? Again, age and smoking are an important risk, but we know that lung cancer risk is quite complex. How do we capture individuals who may not meet even the new revised criteria, but remain at high risk for lung cancer? When we use risk-based strategies, I'll show you how do we counterbalance the possibility of comorbidities. The older we get, the higher the risk of cancer, the more likely that we have comorbidities. What are we going to do about the low rates of uptake of screening in the United States and adherence? People must come back for their low-dose CT. That is not happening in this country. We know that lung cancer risk is very heterogeneous. Developing novel biomarkers that can help complement imaging studies perhaps may be a much better way to identify high-risk individuals. What do we do about access to care so that we take care of lung cancers early when they're detected, but also manage benign findings on low-dose CT without having to do unnecessary procedures that may cause harm? And what can we do better in order to improve tobacco control policies? Critically important, a retrospective analysis of the NLST demonstrated that if individuals were randomized to low-dose CT and quit smoking and stayed quit over 7 years, lung cancer mortality reduction was 38% versus 20%. So underscores the critical importance of tobacco treatment, tobacco interventions, helping individuals with tobaccoism, which is a disease. It's not a habit. It's not a, they should just quit that habit. It is a disease that needs to be treated appropriately. First, have we really eliminated disparities? This was a nice study. Paul Pinsky from the NCI has done a lot of work on eligibility, the criteria for lung cancer screening. Using data from the National Health Interview Survey, he and his colleagues compared the performance of 5 different criteria for lung cancer screening, and they stratified these criteria by race and sex, as well as by smoking status. And then they used a SEER database to calculate lung cancer incidence and came up with eligibility to incidence ratios, EI ratios. And obviously the lower the ratio suggested that there was a possible disparity. These are the 5 criteria that they looked at: the older USPSTF criteria, the newer USPSTF criteria, and they also proposed an expanded USPSTF that is not 15-year quit, but let's be enrolling individuals who had quit 25 years or more, because we know that lung cancer risk does not really go down to 0 or to that of someone who has never smoked cigarettes in individuals who quit smoking. And they also compared a risk prediction model, the prostate, lung cancer, colorectal, ovarian modified 2012 risk model. Importantly, you note that the eligibility for lung cancer screening, it widely varies across all these 5 different models, the risk criteria based on demographics. There are higher IE ratios for non-Hispanic whites across all of the criteria. Lower EI ratios are seen across all criteria for women compared to men. And this is including in dropping the age to 50 and dropping the smoking to 20-pack years. And if we just focus on the new 2021 USPSTF criteria, we have made improvements. There is no question. I mean, here we have non-Hispanic Blacks. Here's non-Hispanic Blacks in the 2013 criteria, Asians for men and women. But we haven't eliminated the disparities. So we have improved the number of individuals across different groups that we can enroll in screening, but there are still disparities in eligibility and incidence. This was another study that looked at comparing the 2013 criteria to the 2021 criteria, men versus women, and then across race and ethnicity. And again, if we look at men and women were not doing so well in terms of eligibility in 2013. It improves, but we haven't really leveled the playing field. And the same is true for Blacks and Hispanic, or Latinos and Latinas. It improves, particularly, but look at this. Look for Black men in particular, higher incidence, higher risk of mortality. So we have to do better, and we need to think about what else can we do to better identify individuals at risk for screening. And as I said, age and total PAC years are a practical way to identify individuals. And this was what was used in the PLCO study, which was where a lot of the individuals for the NLST were drawn from. But we know that lung cancer risk is heterogeneous and it's complex, and it has many other variables that are not taken into account if we just consider age and smoking history. And what is the benefit of using risk models that take into account other variables to identify individuals? And what variables are important? Well, we know that race is important. We know that ethnicity is important. Having an underlying history of lung disease, COPD. See, emphysema and lung cancer are very important hand in hand. And there's probably bidirectional signaling and genetic susceptibility to both, but it's critically important to remember that an individual who smokes and develops COPD, particularly emphysema, is more at risk for lung cancer than an individual who smokes and does not have evidence of emphysema. Pulmonary fibrosis, a personal history of prior cancer. Second primary cancers are, it's about 8% for cancer survivors, and the most common second primary cancer is lung cancer. And having a family history, particularly a first degree relative, these are all very important risk factors for lung cancer. The benefits of using a risk model is that you might be able to replace very, very low risk individuals who might never benefit from lung cancer screening because they're never going to get lung cancer, and identify those who are high risk, but still, even despite the expanded criteria of 2021, still don't qualify for lung cancer screening. This results in not only improving eligibility of high-risk patients, but it improves the efficiency of screening. If you take this approach, you will likely preferentially select Black patients, individuals who are currently smoking, individuals who have this low intensity smoking, less than 10 cigarettes a day, less than half a pack for a long period of time. Men, women, and Blacks are more likely to fall into that category and be at risk for lung cancer. And you're also more likely to identify individuals at risk who quit smoking more than 15 years. But the problem with eligibility based on a risk model is that, again, the older we are, the sicker we can be and the more comorbidities. So we are more likely to identify older individuals and sicker individuals. Again, the risk quintiles, according to the NLST, these were quintile 1 and 2, very low risk. The benefit of the low dose ET in the NLST was seen in risk quintiles 3, 4, and 5. Quintile 5 were individuals who had a 2% chance of developing lung cancer in the next 6 years. That's high risk. So risk quintiles 1 and 2 were very low. So again, the higher the risk, the likely that we are older, that we have comorbidities, and that lung cancer incidence will be higher, but that the risk of dying from other diseases may indeed be higher than dying from lung cancer. And we know that from a lot of the work done by Barcelli and the BOAT score that, you know, these individuals who have very severe COPD don't die of lung cancer, they die of respiratory disease and cardiopulmonary deaths. In the NLST, this is the breakdown of the risk quintiles. About 20% of the individuals had a risk of greater than 2% or high risk. This is on the bottom data from our own lung cancer screening registry in North Carolina. And as you can see, far greater percentage of our individuals in the real world are older, have comorbidities, because we know that in trials, patients who enroll in trials or individuals who enroll in trials tend to be healthier. In the NLST, the majority of individuals were under the age of 65. That's not in what we see in the real world. A more important critical issue is the low rates of uptake of screening. Again, we are now 11 years since the publication of the NLST, or 12 years, I can't keep track anymore, since the publication of a trial that demonstrated benefit to a screening intervention in the most lethal cancer known to men and women in the United States. This is from the President's Council. This was about 4 or 5 months ago. I don't know if you may not have seen this, but there's a great deal. The NCI and the president have created this council to improve screening across all cancers in the United States and access to screening for all individuals. Critically important. And if we look at cervical, breast, and colorectal cancer, this is where we were in 2017. This is where we were in 2017. And this is a little misleading because it implies that we started screening in 2016. Lung cancer screening was approved by the USPSTF in 2013, approved in 2014, approved by Medicare in 2015. We just have not been doing this well. This is data from the American College of Radiology using the database that all screening programs had to report to the ACR. It was sort of a registry, and it looked at screening across the United States. In 2018, as you can see, we went from 3% in 2016 to only 5% of eligible individuals across the country being screened for lung cancer. And when they looked at across states, there was quite a bit of variability. Notably, several states like Kentucky, the highest incidence of lung cancer and highest mortality in all of the United States, has been doing quite well because of a very aggressive lung cancer screening program that was driven by primary care physicians, the Kentucky LEADS program. So several states are doing okay, but none of us are doing well enough. An important observation as well is, yes, we're not doing well in terms of enrolling patients in lung cancer screening, but importantly, Blacks and individuals with low income are the ones that are suffering, right? Access to care, incredibly important. Lack of knowledge about this intervention is critical. So when we look at who is not getting screened, well, you know, vulnerable individuals are the ones that are suffering likely the most. This is very recent data that showed the screening rates are improving. This is 2019 using the BRFS as surveillance data. But the problem with BRFSS is that not all states contribute to this database, but we're doing better. And it suggested that at least in the states that were providing information, that Blacks and Latinos were getting screened just as at a higher rate, similar rate as whites. And what about adherence? So in order for lung cancer screening to work, for any screening test to confer benefit in terms of mortality, you've got to come back. You just don't do one or two. So if you have a low dose CT and it's negative, you must come back every year for that annual low dose CT. That's when the CISNET models were developed for USPSTF, they assumed that there would be 100% adherence to coming back every year. In the NLST, adherence was 96%. In the Nelson trial, it was 87.5. So in clinical trials, patients are coming back. But in the real world, they assumed in order for this to really confer this 20% mortality reduction, people have to come back. Then they said, if that doesn't happen, if adherence is dropped by 50%, well, guess what? Mortality benefit or mortality reduction was halved. So critically important that people come back. We looked at, this is data from our registry combined with colleagues from Kaiser Permanente and one of the Kaiser Permanente branches in California. And we wanted to look at what were the patterns of factors that predicted or were associated with coming back or not coming back after a negative CT, because it's two different things. You do a screening test and it's normal. You got to come back every year. And we looked at centralized versus, meaning a program that has all the disciplines, the pulmonologists, the surgeons, the radiologists, the nurse practitioners, the tobacco treatment specialists, the primary care physician, and this group follows the patients across the continuum of the screening care versus decentralized, anyone can order a low dose CT. And notably, you know, we noted that adherence rates, overall adherence was low, 40%. It improved in the centralized program. In fact, it's statistically significantly better when patients were being seen through a centralized lung cancer screening program. Older age also was a factor associated with coming back for your low dose CT. And other groups have shown that for not only coming back for a CT after a negative, but coming back for testing after a positive CT. That's equally important. Why do we do these tests? If there's something wrong, you've got to come back. And the rates of coming back after a positive CT are higher than coming back after a negative CT, but not where they should be. 100% of individuals should be coming back if we think there's an abnormality on the CAT scan that is concerning. And we have a lexicon for reading low dose CTs that tells us, lung RATS 3, likely benign, come back in 6 months, lung RATS 4A, possibly benign, come back in 3 months, or plus or minus a PET. Lung RATS 4B, highly suspicious, got to do diagnostic testing now. So there are different approaches to a positive CT, but the point is, for this to work, people have to come back not only after a negative CT, but after a positive CT. This is a recent study from the Prosper Group. It's a multi-institutional group across the United States doing lung cancer screening research. And they found that in the centralized program, there was really no difference between Blacks and whites. Everyone was coming back, 76%, which was a reasonable adherence rate to annual screening. But if you look at it, this coming back after in a decentralized program, it was much lower and worse in Blacks than whites. So this is this notion of the centralized, these groups of individuals with expertise across the spectrum of lung cancer screening, lung cancer care, following the patient across the continuum may be better. And you could argue that breast cancer screening has been centralized, right? It's the mammographer, the radiologist that are calling the shots. And that's maybe what we need here in lung cancer. It's a little bit more complex than mammography because you've got multiple different disciplines, but it may be the best option to improve getting screening rates up and getting adherence rates up. And importantly, after a positive CT, baseline CT, there was really not much significant difference in terms of adherence between Blacks and whites. Other factors, so race is an important factor. Multiple studies have shown that Blacks are less likely to come back after a negative CT and less likely to come back after a positive CT. What reasons, what barriers? There are multiple. We'll talk about in a minute. And also smoking status. So individuals who formerly smoked and have quit are more likely to come back than individuals who are currently smoking. Again, socioeconomic status is really important, and this is about access to care. It's about education. It's about knowledge that these interventions are available, but it's about access to care. It's about the ability to pay for these tests. Yes, if you have private insurance and if you have Medicare, you can get a low-dose CT, but if you're a Medicaid recipient in many states, you can't get low-dose CT paid for. And if you have no insurance, guess what? You can't get this intervention for free. There was a federal law passed in 1990 that mandated women had to get free cervical and breast cancer screening. 1990, lung cancer is the most lethal cancer in men and women, and we have no such policies that are at least being considered. And when we look at access to care, this is the geographic, in the United States where we have the higher concentration of Blacks. So the Southern Community Cohort states make up a lot of this area. And this is where we have a high concentration of Latinos. And if we look at across the country where the clusters of low-dose CT and screening programs, guess what? There's a paucity of screening, access to screening in the areas that have high populations of Black and Latinos, more vulnerable individuals. So the importance of this, access to care and the barriers to care, and the fact that all of the screening trials had very, very little diversity. They did not, the NLSC only enrolled 4% Blacks, Nelson didn't in Europe. There were no Blacks enrolled in that study, and 1% Latinos in the NLST. It has been really difficult to generalize these results across very vulnerable populations. This was a really wonderful meta-analysis that looked at all the studies that have addressed inequity in lung cancer screening and looked at it in terms of eligibility disparities, utilization, perception, or knowledge, and then what happens after you are screened. And we talked about eligibility. And in fact, the 2021 criteria have helped quite a bit, We are going to be, if we do it right, we're going to be screening more Blacks and we're going to be screening more women. But as I showed you, we haven't really eliminated the eligibility, screening eligibility disparities. But importantly, Blacks are often not offered lung cancer screening. So there's lack of knowledge on their part, but they're also perceived not to be interested. The same is true for Latinos, although there's one study that showed in a survey that Latinos were very enthusiastic and would opt to undergo lung cancer screening by more than 79%. So this perception that they're not interested, they're not going to follow through. These are the biases that we know exist in our healthcare system. And if you don't know that an intervention and no one tells you and you don't know enough to ask about it, then you're missing out. And we know that this is important because, again, most patients diagnosed with lung cancer are diagnosed at late stage. So you're missing the opportunity to be able to be diagnosed if you're going to get a lung cancer with an early stage lung cancer, and also a missed opportunity for the importance of tobacco treatment and interventions that should be really hand in hand with lung cancer screening. And then what has been shown, at least in studies, in screening studies, is that Blacks are less likely to be offered surgery for early stage lung cancer, even when they are insured. So these disparities are real, they're improving, but they're impactful, and they do make a difference in terms of outcomes. We know that Blacks and Latinos are less likely to be offered surgery, less likely to undergo appropriate staging, less likely to get chemotherapy, less likely to get immunotherapy. This is across the spectrum of lung cancer care. There are many opportunities to improve access to care and screening, implementation and dissemination, navigation strategies going out to the communities with community outreach and engagement. And nurse navigators have been shown to be very, very impactful, particularly for lung cancer screening. This is work that we're doing in the Southern Community tier, which is MUSC, UNC, and VCU, a study that is now ongoing to disseminate nurse navigators into the community and help patients navigate the system, which we know is very complex. Risk-based strategies, how to combine biomarkers. I will just tell you that if you go out into the community and you bring it, they will come. This is a study that was done by Rob Wynn, who is now the director of the VCU Cancer Center. He's a pulmonologist, first African-American director of a cancer center. And at the time he was in the University of Chicago, and they brought lung cancer screening to the community. They said, these patients are not going to come back. They're not going to travel to the University of Chicago. We need to get to them. And when they did that, if you note, the number of Blacks and Latinos compared to the NLST was pretty significant. And if you look at, in terms of who was smoking, much higher currently smoking individuals in the community than in the NLST. But importantly, the cancer detection rate was higher. These are high risk individuals. And this is what we need to do. And this is a study that looked at blood collected during in patients enrolled in the NLST, and they looked at 4 proteins and created a biomarker, compared this biomarker to the PLCO risk prediction model. And the biomarker actually performed fairly well in terms of detecting or a factor of who is at high risk. The problem is only 4% of individuals were Blacks in this study, no Latinos. So we're missing a significant cohort of high risk individuals. I'm going to skip over because I think we're a little over. This is another area of interest of mine, and that's genetic risk assessment using race specific SNPs to try to understand or predict or calculate risk and identify high risk individuals. So just in summary, we now have not one, not two, we have several randomized trials in lung cancer screening that demonstrate there is a benefit to low dose CT because it reduces mortality. That is far better than many other cancer screening interventions, including colorectal, breast, and cervical screening. We are screening more individuals with the revised criteria, but we have not eliminated disparities. Much work needs to be done. And it is complex. There's a great deal of variability. And this is across not just, individuals. This is healthcare systems. These are, clinicians who have not yet bought into the benefits of screening and focus a lot on the harms of screening with low dose CT and not the benefits of screening. The barriers are real and there are many. Just trying to identify who's eligible using our electronic health record, it's impossible. With breast cancer, it's age. And if you have a family history, you have to calculate the PAC year, and it's daunting. We have not been able in the era of technology to, fix this problem within the electronic health record. There are the resources in healthcare systems, and I'm looking at you, no, just kidding, for lung cancer screening are real. Many healthcare systems, academic institutes have not been willing to put in the necessary components, the nurse navigators that are critical for calling patients back and making sure they come back after their screening, the community outreach engagement to go out there and identify individuals, tools in place to be able to better assess smoking history. And that has really been a major, major barrier for many clinicians. It's about time. It's hard to talk about lung cancer screening. It's hard to do shared decision-making. It takes a good 20, 30 minutes sometimes. Most clinicians, particularly primary care physicians, don't have that kind of time when they're seeing patients, every 15 minutes in follow-up. And access to care is, of course, very, very critical. There is work, I will tell you, to address how to better identify patients at risk using biomarkers. This is an area of very, very important research, the development of novel biomarkers in this space. But more importantly, there's a lot of work that needs to be done in terms of getting out into the communities and getting this intervention to all individuals at risk for this disease, not only those who live near the institutions that have these programs. And with that, I'll open for questions. I'm sorry if I went a little bit over. I get too excited. Yes.
Thank you, Dr. Rivera. That was great. I have a question regarding the big side.
Those were clinics in the primary care clinics in the community and identifying radiology programs in the community that would do the low dose CT with the folks which is what we're doing with this project that Rob is involved with, the VCU, MUSC, and UNC, getting navigators out to the federally qualified clinics and centers, identifying patients, helping them navigate the system, get them to radiologic facilities that are close by. They don't have to travel to the big Ivy Tower to get their low dose CT, and through telemedicine and telehealth, be able to provide feedback and results and recommendations for care. So in the MUSC, in the Chicago study, it was the nurse navigators, the screening nurse navigators that are critical because they, calling patients and following with patients, that's a lot of time and effort. The nurse navigators in the community are the ones that provide this benefit, at least in the clinical studies that have been done to date in the federally qualified clinics. And that's the model that we're using for the Stand Up to Cancer grant, where Nurse navigators are being deployed to the community, working directly with the federally qualified centers to identified individuals. So you take it away from the busy primary care physician, and you provide the infrastructure to be able to help patients navigate the screening continuum. The problem is it's how you input the data, and the input is subpar. So in EPIC, when you ask an individual, do you smoke? No. Did you ever smoke? Yes. That's it. So that individual is labeled as, you know, the word former smoker, which should be done away with. These are not smokers, they're people who smoke, right? Because another problem with lung cancer is the stigma and trying to destigmatize this disease. But that's all then you now have someone and it says, but you don't know former, what does that mean? Did they smoke, 50 pack years and just quit a year ago? Did they smoke a pack, 1 year and they quit 40 years ago? There's no way of, and when you have an individual who is currently smoking, and this is just, we did this quality assurance study at UNC where we looked at the smoking history. And when we started, 37% of the histories were correct. We then provided an intervention over a course of 6 weeks where we, had a trained nurse navigator sitting in the clinic with the intake nurse or LPN, helping them get the smoking history correctly using, when did you start, when did you quit, how many, the formula that is promoted as the best to try to get the pack year. The accuracy of the smoking history went up to like 90%. When we left, because, it was a pilot study, we only had funding to do this for 1 year. We couldn't sustain it. It went back down 42%. It wasn't 37, but it was back down to 42% in terms of how accurate the smoking history is captured. So EPIC is only as good as what you feed into EPIC or any other electronic health record. And it requires a lot of manpower to click in and write the accurate smoking history. So you can identify individuals who smoke on EPIC or who have smoked. You just can't identify the pack year history. Yes.
Obviously, we're implementing the EON screening program here as kind of the software backbone. And Cliff and Fez have really been diligently working along with the primary care to get the automatic alerts through Cerner, capturing all of that information so we can have pop-ups that this patient will be eligible for screening. So they're working very diligently to try to make that a reality within Cerner.
Yeah, and there is software, the EON platform, that it was designed initially to follow incidentally detected nodules and then evolved into a platform to help you track individuals who have nodules detected in screening, but also are they coming back, et cetera. But yes, there are, again, it's pretty sophisticated that we can, stream 1,071 different channels. And, I don't know, I like 75 million apps on our phones, but we can't get the electronic health record to work.
Thank you, Dr. Rivera. 2 questions. Did they examine the frequency of the lung cancer screening, whether 1 year, 2 year? How did they come up with that kind of formula for annual screening?
So the NLST did it annually for 3 years and then followed patients for a duration of 7 years. But the cancer detection rate was the same at every year. So the best we can say is it has to be annual, or we believe that annual low-dose CT is the most effective until you reach that age where you think, okay, the risk may outweigh the benefit at the age of 80. Although I would argue, the older we get, the higher the risk of cancer. The Nelson trial did look at intervals. So patients were randomized to intervals, 1 year, 2 year, 2.5 year. And the missed cancers in the 2 and 2.5 were real. So they concluded that it should be annual low-dose CT.
And then why do you believe that if in, I think you said 1990, they mandated, free mammography and cervical cancer screening. What's the disconnect with lung cancer screening?
Advocacy. There's no stigma associated with breast cancer, right? It is, a disease that women face. It is family history is a risk. But the link to smoking with lung cancer has been detrimental. It's a very important risk factor, but we have blamed the individuals who smoke for their disease, in my opinion. They blame themselves. And I think our healthcare system in our society has blamed the individuals. So the stigma around lung cancer is real. I trained at Sloan Kettering, and Pat and I took care of a lot of very famous people with lung cancer. We tried on Diane Stover, not we were just, Diane's peons, to get some of these very famous people to advocate about lung cancer. No way. And people didn't die of lung cancer. They died of brain cancer. They died of bone cancer, the lung cancer that has metastasized to the bone, the liver cancer. Never. So Sting died, not Sting, I'm sorry. Bowie died of lung cancer. The Beatle, what was his name? Harrison died of lung cancer. On his obituary, it said he died of brain cancer. So that's a huge issue that we have. The stigma that is just evolving, wrapping this disease is real. And the American Cancer Society and the National Lung Cancer Roundtable have really launched very aggressive initiatives. They actually had a stigma summit in 2020, right before the pandemic, to really address this very important issue. And for example, changing our language. People are not smokers, they're people who smoke. And it isn't a bad habit that you should just quit. It's a disease. Nicotine is the most addictive drug. This is a disease. Tobaccoism is a disease, and we've never treated patients appropriately. We don't offer, you can't pay them for pharmacotherapy for tobacco treatment. Many insurance doesn't cover it. The Affordable Care Act was expanded primarily to expand coverage for tobacco treatment in many states. There are 9 states in the United States, the last time I looked, that did not expand the ACA and offer no tobacco treatment or lung cancer screening, so to Medicaid recipients. So that's the difference. That's the difference. We don't have a Susan Komen race. November is Lung Cancer Awareness Month, and our pin is clear. So no one really knows what that, if you're wearing a red jacket, it looks red. If you're wearing a blue shirt, it looks blue. We have struggled with, it's changing, it's slowly changing. And it's changing because of, in my opinion, lung cancer survivors. They're the ones who are giving a voice to all other individuals. So advocacy is really improving, but there's still a great, and it's not just, individuals feel very guilty. They don't want to tell you how much they smoke. They don't want to talk about it, right? And I think the healthcare system is still, blames individuals.
We have a lot of people interested in asking questions. I am just going to relay one question from online, and Dr. Rivera, I'll ask you to repeat it. Do you have recommendations about practical ways to educate providers to overcome their biases?
Oh, do you have recommendations for educating clinicians about bias? I think it's very difficult. I think we all have bias, and that's the first thing we have to understand. I think institutions are becoming a lot more proactive about having workshops and learning modules and teaching tools. The NCI has created a new pillar to all cancer centers that they have to have a diversity, equity, and inclusion division, and work on interventions and strategies to diversify the workforce within cancer centers. So that's not to replace community outreach engagement, which is a critical aspect of getting individuals in clinical trials. You know, lung cancer is the one, I mean, when you look at clinical trials, if you look at the immunotherapy trials, I don't know how many medical oncologists are here. They don't even report race. It was like 98% whites in the first 2 immunotherapy trials, which were impactful in lung cancer. So there's a component of getting individuals in clinical trials and getting individuals to have individuals receive guideline recommended and guideline concordant care, education of clinicians and trainees about the importance of healthcare disparities and bias, but also diversifying your workforce. But at UNC, we had to do annual workshops, but it was just a module. At the American Thoracic Society and at the American College of Chest Physicians, if you're an officer, it's mandated that you attend a 2-day workshop with a trained diversity, equity, and inclusion officer, someone who is trained to deliver this content and educate individuals before you can take office. And I think those are the interventions that we need to have in place across healthcare systems.
Thank you very much, Dr. Rivera, for your lecture. I think as a thoracic surgeon, we became very early on believers in lung cancer screening because those patients who were identified early kept coming back to the office, and you got Christmas cards from them for years and years. But I think clearly the challenge is getting patients to the screen, and that's where all these methods that you have mentioned before are very critical, and then navigation to help us reach different programs. One thing I will mention that New York State just approved the first mobile scanner
Yes.
to bring to communities that are challenged because there are significant transportation issues. And so, you know, that's starting in Western New York,
Yep.
you know, and so that I think that'll be a benefit, and we can maybe look for some of our issues. But one thing that you haven't had,
Although they're really old, but that's okay. We'll take it.
One question I have for you is if you could make a comment as to the all-cause mortality reduction that was seen in lung
In the
cancer
NLST?
screening.
Yeah,
And
absolutely.
so, and to how you follow up all these other incidental things that really impact
I'm putting in a grant
survival.
on this. Oh boy, this is like my second favorite topic. So yes, so the all-cause mortality in the NLST was not statistically significant, but it tended toward improvement in the patients who had been randomized to the low-dose CT, 6.7%, because of the detection of coronary artery calcifications and interventions in individuals found to have moderate to severe coronary artery calcification. That was the benefit, and it's critically important. And the benefit or the harm, whichever way you want to spin it, of low-dose CT is not only are you looking at the lungs, but think about everything else from, you know, from the neck to sometimes even the lower part of the liver. Incidental findings are problematic to some extent, but I think of incidental findings as added benefits to lung cancer screening. Coronary artery CT scan is now recommended at a certain age when studies have shown that the low-dose CT is just as good as coronary artery CTs for identifying and quantitating severity of coronary artery calcification. The concordance is pretty good between the two. And this is data published by, Carolyn Childs, a thoracic radiologist at Wake Forest, who was part of the NLST. So the benefit of the low-dose CT for cardiovascular disease, I think, is real. I think it's also quite real for detecting severe emphysema. Remember, PFTs are not paid for when you want to screen for emphysema, right? Think about it, unless someone is symptomatic, for bronchiectasis, for aortic dilatation, For adrenal masses, I've detected a renal cancer and a thyroid cancer on a low dose CT. So those are real, but in the NLST, the benefit, although not statistically significant, was better in those who, undergoing low dose CT because of the detection of coronary artery disease and then intervening in those patients.
Thank you, Doctor. I'm wondering where all the other forms of smoking come in that's developed now between vaping and marijuana. Are we just talking about cigarettes and tobacco here versus?
Yes, so we unfortunately, it's difficult to quantitate marijuana use because unlike cigarettes where, we know an individual will smoke one cigarette a day, one pack a day or 3 cigarettes. Marijuana, from what I understand, you don't smoke a whole marijuana cigarette at once. So maybe you do, I don't know. I don't know, but maybe you smoke a little bit and then you come back and you smoke it again another day. But we really can't quantitate. But what has emerged from vaping and marijuana is significant airways disease, particularly bronchiolitis, follicular bronchiolitis, follicular bronchiolitis, so pretty severe airways inflammation. But in terms of lung cancer risk, we're not there yet. Secondhand smoke is important, but the risk is really low. What is really critically important, and it should be even more frightening today when the Supreme Court reversed all the laws to protect the environment, is that environmental exposure is a pretty significant risk for lung cancer, particular matter of 2.5 micrograms. And there are groups in the world, there's a group in Canada that's, launching a very important study if it gets funded, that's looking at particulate matter exposure. And it's also critically important because it dovetails with socioeconomic disparities. So in certain parts of the world and certain countries of the world, it's going to be far worse but in certain parts of the country is worse than in others. But that is a very serious risk. And there was a very nice paper published in 2015 that looked at lung cancer deaths attributed to just environmental exposure or particulate matter, and it was pretty significant. So this is now gaining the attention. The International Association for the Study of Lung Cancer, ISLAC, is a it's an organization that encompasses all nations and individuals who are dedicated to lung cancer care. And they're doing a lot of work on this. This is a major issue. Radon exposure is also quite important. It's probably a significant risk for individuals who have never smoked. So I think cigarette is just one part of the tail. There are many other risk factors that need to be considered.
Thank you. I'd say we have time for 1 or 2 more questions.
Dr. Rivera, I was very interested in the blood marker talk, and there's something called GRAIL, cancer screening tests. I know they're very expensive and not
But
very.
that's for individuals who, we use a GRAIL for individuals with lung cancer. You mean to detect genetic mutations?
All right. I just wondered, well, is that going to become a more practical screening test?
So in the lung cancer, right now, the biomarkers in the lung cancer space are biomarkers used when you find a nodule. There are about 7 biomarkers that have been studied, and they're at very different stages of the process. Some are in the validation, some are in the early phase of discovery. Some are the Notify XL2 by one company is went through a validation study that's been published already in CHEST, and now there's a large multi-institution randomized trial. So once you have a nodule, there are several biomarkers that are being studied and some that have been already approved that can help you make decisions about what to do next. In other words, for indeterminate nodules, how concerned am I that this is a lung cancer versus a benign lesion? Remember, the majority of nodules are not cancer. So there's you have a nodule incidentally detected. There are about 7 biomarkers that are available. Most of them are in clinical trials. The biomarkers are being developed to better understand who may be at risk for developing lung cancer. And using a blood-based, DNA test that can help you detect individuals that are going to possibly get lung cancer, that's a better way to identify a high-risk group that should undergo screening, and maybe a lower risk group that has that meets criteria because of smoking, but maybe they don't need to be screened every year. So that is all in infancy, but that's where the future, I believe, of screening will be in terms of detecting biomarkers that help us predict risk, right? There's some in breast and colorectal. This is important. In terms of, so I'm familiar with, and then there's the biomarkers in individuals who have lung cancer. And those are the molecular biomarkers to identify a targeted mutation. And now I can't keep up anymore. I know there's, again, medical oncology, I think there's 9 targets that now have a drug approved, an FDA drug. And the reason why that's so critically important is because if you have an adenocarcinoma of the lung and your tumor has an EGFR mutation, you're going to do far better if you're treated with a tyrosine kinase inhibitor against an EGFR mutation. If you have an ALK, a ROS, a MET, a RET, a KRAS now, we have a drug for GC12. So the importance of finding the target in these cancers is critical, because that is what is going to determine what is the best treatment. And the paper that was published in 2020 in the New England Journal of Medicine that looked at the incidence and mortality from lung cancer. And since 2016, the drop in incidence, but importantly, the drop in mortality was pretty significant, more so for men and women. Why is that? They believe it had a lot to do with targeted therapies, with individualized, personalized precision therapy for metastatic non-small cell lung cancer. The same is true for immunotherapy. So the other biomarker is PD-L1 expression. And if patients overexpress PD-L1 and they have metastatic lung cancer, they should get an immunotherapy drug first line. They will do better. So across the spectrum, I think once you're diagnosed with cancer, if you have an adenocarcinoma, or if you have a squamous and you never smoked, or if you have an adenosquamous, you must have molecular biomarker testing. All patients with advanced lung cancer must have PD-L1 testing. Then there are the biomarkers in the nodules, these indeterminate nodules where could be cancer, maybe not. Should we needle it? Should we take it out? Should we watch it? And then in the sort of before you even start the intervention, can we identify the high-risk individuals?
Dr. Rivera, I'm Jose Mendez. I'm a pulmonologist, and I was wondering if you can comment, thank you for the lecture. I was wondering if you can comment for those gray area patients. In my 16 years of practice, I found more cancers in patients that did not meet the guidelines for screening, and I had to finesse my way around to get it,
It's
get a CAT
very
scan done.
challenging. This
And I don't know if this
comes up a lot. What do we do? 20% of lung cancer is diagnosed in individuals who have never smoked. The problem is the only data we have is in individuals who smoke and who smoke a certain quantity and who are of a certain age. We have no data on how to approach lung cancer screening in individuals who have never smoked. It's a really challenging space, unless it's an individual who harbors a T790M mutation. There are cohorts of families with EGFR mutations, the T790M. Those individuals should be screened regardless of age. That's a very small % of the population. But what do you do with an individual who quit 25 years? So when I do shared decision-making, I use the shouldiscreen.com. Are you familiar with that platform? Shouldiscreen.com has the PLCO 2012 embedded, and you can sit with a patient and calculate their risk. So you plug in their age, their smoking history. Have you ever had COPD? Have you ever had cancer? Do you have a family member with cancer? Do you have COPD? I mean, all these factors, and it will calculate a predicted risk for that individual. And if that risk is greater than 1.3%, which is risk quintile 3 in the NLST, and actually it will say, even though you don't meet criteria, you should talk to your doctor because you might benefit from this intervention. So I calculate a risk on every patient I see. And in patients who don't meet criteria, I talk to them about if their risk is greater than 1.2, 1.3, I can't remember. I recommend screening, and then I fight like the Dickens to get it approved. You don't want to be ordering just conventional CT scans. You really want to do it right, because you want to order the low dose CT so that it's read with the lung rats recommendation so that you can enroll that patient in annual screening. I have been able to get insurance companies to pay, and Medicare. Medicaid is a lot tougher. And especially in individuals with a prior history of cancer, head and neck, bladder, prior lung cancer, colorectal, breast cancer in women who have received radiation, and particularly women who smoke. So there is, I mean, it's a lot of work and effort, and hopefully the eligibility criteria. I mean, this is the work now, right? It took us 10 years to, hey, we got to bring this age down, and we wish we had expanded the quit rate, but the quit years. But now we're working on how do we do this better?
Thank you, Dr. Rivera. Thank you so much. I can't think of a better way for us to celebrate Pat's memory than having this really important discussion about improving the care for the patients that we take care of. We will adjourn to a very small reception just outside. You're all welcome to join us. And again, thank you to everyone who was able to attend. This was an incredible discussion.
Yes, it was. Want me to stop share, right?
Yeah, I think, Beth will take care of it.
And how do you, oh.